Welcome to yet another episode of Shortcast Over Coffee. Today, my guest is Dr. Sanjay Nagral. Dr. Nagral is a leading Indian surgeon and a medical ethics expert. He is a hepatobiliary and pancreatic surgery specialist based in Mumbai, where he serves as a professor and a postgraduate teacher. Dr. Nagral has published extensively on surgery, public health, and medical ethics issues. And this episode is going to be an in-depth discussion on all these issues. Please do like, share, and subscribe this channel as it will help us get such great guests on. And for all the audio files, do check out the show Shortcast Over Coffee on top podcast platforms like Spotify, Apple, etc. Now, without further ado, let's dive right in. Dr. Nagral, thank you so much for joining the podcast.
Thank you very much. Thank you, Bala. It's nice to be with you and look forward to this conversation.
Absolutely. Likewise. Dr. Nagral, you have been in the field for over 25 to 30 years. Would you like to tell the audience a bit about how you got started and what you do?
Right. So I was like any other kid growing up in the India of the uh, 80s, after, of course, school and science education, early science education. Uh, there was, of course, the choice was at that time was engineering or medicine, right? And so I gravitated into medicine. One reason, of course, was that my parents uh, were doctors, and and at that time, really, as I said, becoming a doctor was considered uh, something very important and good to do. Not that it has changed much, but I because of of this kind of family background and as I said, the classic competitive students of that time, it was either medicine or engineering, IIT or otherwise. So that's where I landed up, and so I studied in Mumbai. I went on to do surgery. That is something I look back and ask myself, what is it that again made me gravitate towards that kind of field? And I think it was for many male medical students at that time. Surgery seemed like a classic choice. We also had, of course, a lot of very towering, impressive personalities in the surgical field in the medical college. So I guess it was a bit of being attracted, looking at their personalities. So that's how I landed up with the surgical career. I did my post graduation, then I went on to teach actually in the medical college along with clinical work. And then I developed an interest in liver surgery, partly because of early exposure working with people who were interested. And that was around the time when there was a lot of early excitement about transplantation of the liver. Uh, uh, in India, which the transplantation had started in the West earlier, but at that time there was no law which enabled transplantation in India. There was only kidney transplantation. So uh, I got interested, curious, and then finally ended up traveling to train in liver transplantation. And this was in the UK in a large hospital in London, where I saw, worked, participated, and actually became a part of the surgical team in a large hospital there. And it was very exciting because this was the field of cadaveric transplantation, or what is also called disease donation. And I saw a highly organized system because this was the NHS and the UK. And we would travel all over the UK in small flights and go and procure organs from those who had been declared brain dead or brainstem dead, and would bring the organ back and transplant them in the hospital. And clearly, it was a very successful project. Clearly, it was saving lives. And therefore, it seemed like something that India should move towards, because obviously we had our share of patients with dying of liver disease. So I came back, uh, spending around 2 years in the UK, and I actually I did join back the public hospital in Mumbai where I was working and teaching, spent another 1.5 years there, trying to see whether we can establish transplantation there. And that's another sort of discussion as to which I can come back to later, that why is it that the public healthcare system in India has not been able to develop uh, transplantation, especially of organs like the liver and heart. Now, there are lots of transplants being done in India in the private sector, but somehow the public sector has not been able to take it up. And then I left. Um, I joined a private sector hospital. What I also did was that I worked part time in again a large public hospital in Mumbai. So for a period of almost 20 years, I would spend time both in the private and public sector in Mumbai. Hospitals, uh, I would say half an hour to 45 minutes away from each other, but two different worlds. And it's quite a schizophrenic kind of existence. Those who have seen both the worlds, those who have worked in both the worlds will maybe understand what I'm saying. But really, one of the astounding features of healthcare, at least in large Indian cities today, is the kind of difference one can see between the large uh, private hospitals, what is now termed as corporate hospitals, whatever that term means, and hospitals which are public hospitals. And these are cheek by jowl, side to side. So I was working in that fashion, and then well, so coming to why and how I decided to start talking and writing about some of the issues I saw around me, and this is partly, you can say, to the combination of maybe in my early career. Of course, I had connected with several uh, movements in India which were articulating ethics. Some of them were articulating right to healthcare. So I was connected with them. I was working with them. But also, I saw in my work uh, uh, a stark differences, uh, to the extent that we were almost, to put it a little simplistically, but I think it captures it quite well, and therefore I am using that bit of a cliche that the poor in India, and I think that still holds, are grossly undertreated, whereas on the other hand, the rich are often overtreated. Uh, so this is probably a good description of what is happening, and I bothered me. I started articulating it, then I started writing, and uh, to my surprise, I realized that people want to know more. I started getting a response, and I started a column in a Mumbai newspaper, which is quite well read. The newspaper also was very well read. And what happened was that then we hit COVID, and during COVID, I was writing every week, um, and that column garnered a lot of support, feedback. Started getting more invites to write. In the meanwhile, some of us who were writing, we were also writing in the academic space. So, for example, the BMJ, the British Medical Journal, was also interested in knowing about what's happening in healthcare in South Asia. And then one of the areas they wanted to for people to develop and write is uh, why was there so much corruption in healthcare? And so we wrote on that and actually ended up writing a book. And this book created a stir, as you can imagine. It's a book on healthcare corruption in India, which I co-edited with two fairly senior and well-known co-authors. One of them was the ex-health secretary of India, and he passed away uh, this year, Mr. Keshav Desiraju, and the other was a very senior surgeon colleague from Delhi, Dr. Samiran Nandi. And we actually took a deeper dive into uh, these what is typically talked about as a scandal, but really is a system challenge. And the word corruption usually connotes some petty kind of exchange of money under the table, but I think in healthcare it is some different dimensions. So this book came out, and then of course, as I said, started writing. Uh, Also a little bit on social media, but I think that's where I am now. I'm writing regularly. I'm still not quite sure uh, how it resonates. I mean, it seems to resonate amongst people, uh, but amongst my colleagues in the profession, I think, of course, there's a question mark on how they respond to it. In the sense, I see a wide spectrum of responses, from the clear hostility, uh, sometimes very sharp hostility. When we wrote the book, for example, we had this huge backlash on from our colleagues who said that why are you washing dirty linen in public? That's the standard trope. Incidentally, many of them had not even read the book, but it was a huge campaign, and some of the calls for a boycott, etc. Uh, I had to write back to some of them whom I knew, saying that first read the book. This is not a scandal book. This is not a steamy sort of expose that you may be thinking. Oh, it's a deep dive into the way the historical process, the compulsions, the inherent conflicts of interest in a highly privatized system, etc. So yes, this has been a journey. I don't think that I have often, when I look back at my writing, it's not that I've always said something highly original. This has been written about both globally and in the Indian space. Maybe it strikes a chord partly because I'm an insider, and I think that to an extent matters, because there is a lot of academic analysis of healthcare and even healthcare corruption, or the the way the private sector has grown. What may be called a very predatory kind of private sector. But because I was an insider, I guess uh, it had a bigger resonance. Also, I think there were some areas of this on this topic where I being everyday involved, could maybe dissect a little better. So, how do doctors think? What are the pressures? What are the conflicts of interest, etc. So maybe that's maybe a little different from some of the other writing, but a lot of the things I have written about have been known. I have shared a lot of anecdotes, actual patient experiences around me. In COVID, I did a lot of that, and that seemed to also resonate a lot, because I talked about what I see around me, and So I think right now this is where I will stop, and maybe we can take a deeper dive into some of the areas.
Yeah, absolutely. You mentioned that the poor in India are grossly undertreated and the rich are overtreated. And I wanted to sort of get an insider's perspective, someone who has worked both in India and the UK. What were the differences as a doctor that you saw in the UK that were completely different from India?
Yeah, so I think first of all, let me start by saying that these comparisons between countries, of course, have we must acknowledge have some limitations, partly size of the country, etc. Having said that, our comparison with the UK is very important because we were ruled by the British. They laid down a pathway for us during after independence, the famous Boer Committee, which almost recommended something like a NHS in India. And one of the big questions is why did we go to another pathway in terms of how we have developed? So the UK, as you know, is the NHS, and I'm not going to analyze the NHS. It's fairly well known. But what I saw was, first of all, uh, and which astounded me, was completely a system which does not ask you about money, your background at the point of entry when you seek healthcare. So I think that is something very different uh, from what we see in India and some other countries. The second was a high level of trust by ordinary citizens, high level of participation. They almost feel that the NHS is something that they want to protect. Uh, Also, I saw that the the average doctor who sets out to be a professional in the UK is not primarily coming for money. A lot of it has got to do with science, professionalism, and I think that also matters. And the system also is not making heroes out of money, uh, making an example out of money, but making an example out of good work, scientific practice, etc. Uh, so this umbrella of care and the responsibility taken by the state and the system to offer care. So just to give an example, so in India, let's say you have a patient who is critically ill in a hospital and has to be transferred to another hospital. And that happens all the time here, both in the public system, sometimes in the private system. The entire onus of the transfer today is on the patient or the family. So they are told, okay, you get an ambulance and you take her. And sometimes there is a bed arranged, or there may not even be a bed arranged. There may be just told to you take them to a bigger hospital, and then the ambulance is roaming from place to place. Whereas in the NHS, and they do transfer very often, it is the responsibility of the hospital. They will ensure that there is a bed available in the referral center. They will be providing an ambulance. They will ensure that you are safe in that travel. And I want to immediately bring one more point, which is, and I bring it up because this is often the subject of discussion in India, which is that everybody has this notion that, oh, but the NHS has huge waiting lists. Uh, so I must debunk this waiting list, confusion. So of course there are waiting lists. In India, I see a patient today in my private practice, and the patient needs surgery. I can do it tomorrow. So that seems to appeal to people that there is no waiting list here. But the reason that system does it, where they have a waiting list, is two. One is that it's a system which strongly behaves on believes in triaging, right? So they give priority to those who need emergency or early surgery. They are not. The system is not geared to sort of just look purely at so-called efficiency. And efficiency in India means if you have the money, it's efficient, right? So therefore, if you need a knee replacement, it's never an urgency, right? So they may tell you, okay, as per our current list, you will get it after 6 months. Because it's an organized system which is prioritizing other things. And anyway, many of these procedures don't need to be done immediately, right? In India, of course, because it is the private sector, and clearly there is a huge incentive to perform the procedure, they will do it tomorrow or day after, right? Now, that is perceived as efficiency without perhaps understanding that in an emergency in the UK, if you need a procedure as complicated as, let's say, a bypass, an emergency bypass for the heart, or even a liver transplant, they will do it, no questions asked, no money involved. Here, you, in an emergency in the night, if you arrive at a private hospital in India at 1 a.m., you may be told to pay a deposit of 2 lakh rupees. So that's what it is. So I think, therefore, uh, that's the strength of that system. And that's a mystery, because if you look at the board committee, if you look at the early days post independence, we inherited so many institutions from the British, right? Uh, so why did we not inherit the idea of an NHS? And I think that's been a subject of uh, great curiosity for me. I've attempted to write on it. I've actually asked scholars and I've asked colleagues, including historians, that where do you think we swerved away? Because very clearly, after the initial decade or so, we chose to go to a system which was so-called mixed, which means we developed the public health infrastructure, but clearly very early started developing a private sector. And now, of course, in the last 2-3 decades, built a huge private sector. And I'm sure, again, this figure has maybe come to your notice and people know this, but just to repeat, India is, and which people don't appreciate, that India is the most privatized of healthcare systems in the world, even more than the US. And I'm talking of the highest form of privatization, which is out of pocket payment, right? And insurance based payment now to an extent, but out of pocket payment. India is the most privatized. This is where we have reached. But there is another important thing. And again, this is important for certainly for citizens to understand, which is that, and I'll come to the view on this from the medical profession later, but we are also one of the least regulated. So there's a feeling that, there are lots of rules, laws, but, you have to just talk to the doctor in the US. And, I have seen the US system from very close. Of course, it's a private system and there's huge challenges. I know that with experience of my own family members, etc. But it's highly regulated. Whereas we have a strange combination of a highly privatized system, which is also very limited regulation. So, just again to give an example, today I decide, I have this brainwave today that, look, I have some money and I want to start a hospital. So I can just go somewhere, buy a piece of land and start a hospital. Nobody's going to ask me, why are you starting a hospital here? How many hospitals are there in that area? What is the need? Okay, if there is a need, what sort of hospital should you be building? I can start yet another large private hospital. And there are cities in India where you will see that on one street, there are 4 large hospitals. Now, if you look at it from the viewpoint of planning and access, what does it mean? Yeah. So I think this is where what I talk about regulation. There are, of course, now we're talking of standards, we are talking of rules. But COVID was an example, right? Where, the government actually had to step in and cap fees, which means that otherwise there is no rationalization of fees. I mean, this is an open secret that in India's private sector, fees, there is nothing like rationalization of fees. I do not have to explain rationally in detail why something is charged in the way it is charged. Of course, now there is pushback. Of course, now there is an attempt to rationalize and structure it. But really, uh, so here is what I say, that even if it is a privatized system, uh, in healthcare generally, and parts of the world which is insurance based, there is a control of sorts, either from the payee, who is the insurance, and the US, for example, is an example of insurance based healthcare, but also there's one more thing which is been lacking, which is that there is the consumer resistance. And that is, again, classically explained by economists, that healthcare is a sector where consumer resistance is the lowest. And the way it is explained, and I think it's true, is that when it comes to your own health, when it comes to a crisis especially, your ability to offer resistance is very low. First of all, you are intimidated. Then you are scared. It's an emergency crisis. You don't want to displease the doctor or the hospital because you feel that there may be pushback. So consumer resistance is also very low. So this combination, and the state's ability to control, either is structurally low, or they don't want to control. Only in COVID, for example, they capped the prices of ICU beds. And do you know that there was a medical association in my state, in Maharashtra, who took them to court, saying that how can you cap charges? And there's a court judgment from here which says that, oh, but this is a private hospital, and in private sector, how can you cap charges? The court also said that. So a crisis of the magnitude of COVID, uh, there was this idea that, so what, you can charge what you want. Now, by the way, we would quickly add that since there were capping of charges, at least there was a structure in place. So after COVID, in this state, because of a lot of activism, people have been returned money. There have been thousands of cases who were overcharged and they have been returned money. So this is the level of kind of dysfunctional, unregulated system which we have come to. And again, we can look at this, but I think the big question here is, what is the role of the profession? What are we? Are we part of the system which is basically profit driven, or are we a third party which also needs to look at our patients' interests? And I think that is where that's the key point at which we are. That the medical profession needs to decide where do they stand, because obviously there is pushback now. Governments are increasingly interested, so they are trying to intervene. Many governments have started capping charges. There's right to healthcare bills being passed, which is opposed by the medical profession. And that is astounding if you think about it. It's shocking. Why should a right to healthcare bill be opposed by medical professionals? As a doctor, if my ordinary citizens have a right to healthcare, it should be a great idea, right? Because it allows us to benefit and treat our fellow citizens. But there is opposition. There is opposition from the Indian Medical Association. And then you begin to dig deeper and you realize that there are huge conflicts of interest. And we can talk about that, but I think that's a big challenge. The way it has progressed, if the citizen gets empowered, if costs are controlled, it affects my practice or it affects my income. And that's the contradiction which is going to be the biggest challenge for us.
Yeah, people who oppose right to healthcare, the doctors should also realize that doctors also eventually become patients at one point or the other, right? Yeah.
Yeah. So I mean, yes, of course, but I've said that, but doctors are largely in India are privileged, and therefore, for that matter, the real well-to-do section, they feel they're privileged, they are insulated from all this. Is partly failing. And I'll tell you why it is partly failing, because when they actually are on the other side, uh, sometimes they realize uh, what a challenge this is. I give this example, and it's happened to people I know. So I've been writing about the lack of emergency care in India. It's in a very sad state. Now, it may not resonate with you if you read that we have poor emergency care in India. So, for example, India has an epidemic of road traffic accidents, one of the highest in the world, right? Now, you may be well to do, but you can be trapped in a accident 1 hour from Bombay, 2 hours from Bombay. Uh, you can be involved in an accident. And that is when you realize that when you don't get an ambulance, you don't get help, you die because you don't get care in that first golden hour. That is when probably you realize that, look, we what is the point of having state of the art, into inverted commas, hospitals in big cities, when 1 hour from the city you can die of bleeding? So I think that is people are they realize when it comes to their own. In COVID, people realize this. So the first time in at least in Mumbai, and I suspect happened in many other cities, the well-to-do, privileged realize that what does it mean not to get a hospital bed or to wait to get a hospital bed. I got hundreds of calls, and some of them were people with mild COVID, but didn't even need hospitalization. They would call and say, "I'm not getting a bed. Do something. What is going on now?" Of course, that's a challenge, but every day in this country, ordinary people have faced the same challenge, being going from hospital to hospital. There are stories every day in newspapers, but we don't connect to those because we know that it's not going to happen to us, or at least we believe it's not going to happen to us. And it probably doesn't happen to us on a day-to-day basis, but it happened in COVID. And I wrote about this, and I said, look, this is the time. But interestingly, Mumbai, maybe you've heard of the Mumbai model. So the Mumbai Municipal Corporation got into the act of having a centralized, what they call war room or something, and they put together. So they connected all hospitals for beds. But the moment COVID is over, it's gone. Now, it has the same application for other emergencies, for let's say road traffic accidents, trauma, but it's gone. So that's where we are, and I think this is also the challenge, that for those who can understand, analyze this, maybe even make a difference, uh, feel that it doesn't affect them. Not just that, but when I started my career, there was a lot of middle class people who would access healthcare in public hospitals, a substantive number. That's gone now. I can tell you that nobody I knew during COVID, yeah, across the spectrum, the very well-to-do, the upper middle class, the lower middle class, whatever way you classify them, actually ever got admitted to a COVID hospital or a COVID ward in a public hospital. They all managed. Some of them got admitted, and within 2 days, they got themselves transferred out uh, because they perceived that I am not sure whether the care was really inferior. Majority of COVID cases didn't really need huge care, but certainly when they needed intensive care, they perceived that. So I think even the middle class now doesn't access public hospitals, and therefore it is. So the big government hospital, the corporation hospital that I worked in a suburb of Mumbai, I retired very recently. But so we look back at we used to get a lot of railway accident victims. We've actually analyzed a lot of that, and we've got a paper on that also. But there was a very interesting piece of data which my resident doctors used to tell me. They used to say that in the casualty, if it was a first class patient, Bombay's trains have a first class and a second class, they would come and they would be whisked away by their relatives to a nearby private hospital. It was the second class patient whom we would be treating. So there's this clear sort of, because, and I don't blame them. I'm not at all suggesting that. I don't blame them. Honestly, today, if I have a illness, I feel sorry to say this, but I will not access a public hospital for an illness. So I think this is the challenge. And so the only value today of public hospitals in India for the connected and those who are influential uh, is for education. So medical education still, people would prefer public institutions. But otherwise, as centers for healthcare, and even the political class, right? I mean, when is the last time one saw? I mean, there was a news item once that in Chhattisgarh, a IAS officer actually took treatment in a public hospital. There was a news item as if it's some rare occurrence. So so that's where we are, and I think it's a complex challenge, and there are. I mean, I'm not here to sort of say that people don't have the right to access the care they want to. Of course, they have the right. The question is, what is it? What does it mean collectively?
Yeah, I do have a personal experience where a close family member of mine who was living in Mumbai had this challenge of getting access to a bed, and her son tried extremely hard, and in one way they were privileged and they did find her a bed, but unfortunately she passed away. So yeah, I think when you talk about it, it deeply resonates with me as well. um, Doctor, you talked about Indian healthcare system being hugely privatized, and I just want to understand this a little bit more. I live in the US, and there is no concept of government medical college or public healthcare here in general. Everything is privatized. But in India, there are medical colleges. If you are met with an accident or got injured, the first thing they do is to transfer to a public medical college. So when you say India is more privatized than the US, can you explain me what you actually mean by that?
Yeah. So first of all, US, of course, we need to define what is private and public. But so the US, I understand, and I have sort of never worked in a long manner, but I have seen US hospitals. I've spent time. So you're right that most of them are run by private entities, right? But they have been incorporated into a system. So so in the US, for example, my understanding is that if you have an emergency, uh, if you go to the nearest big hospital, they will not refuse to treat you because you are from a poor section of society. There may be inherent biases, I'm aware of that, but so there is a sense of public accountability. So let me put it that way. Also, of course, insurance covers a significant proportion of American citizens. I'm completely aware that there is a significant proportion who is not covered. Yeah. Uh, when we now talk about India, so the insurance penetration, first of all, is still extremely low. I'm talking of private individual insurance or employee insurance. Now, on the other hand, most ordinary citizens, including the poorest of the poor, when they need even day-to-day healthcare, they go to a private doctor. Why do they do that? Because private doctors are accessible. Um, it seems that the waiting periods to see the doctor will be low. They are near their house. They are more convenient. Now talking of family doctors. So if you go to so in the slums of Mumbai, 50% are in the slums. There are lots of general practitioners who serve people literally next door. So the only reason they will come to a hospital is if it's something significant. Now, these are all private doctors. There are public dispensaries of the Mumbai Municipal Corporation. Normally, since those dispensaries are free, right? people should access them. They should be extremely overloaded. Why should there be a private doctor in a area where people have challenges of paying for healthcare, who is doing very well? Because of I think the other factors. People say, look, going to the government doctor, the government institution, waiting in a long line, uh, sometimes being not treated respectfully. Now, this is something I bring in slowly, but uh, it seems, and I think it is true, that in the government sector, and I worked in the government sector, I trained in the government sector, and I don't say this as an outsider, but we have sort of dehumanized it a little. So, for example, in the OPD, there is a patient. So the way it is conducted, so people have questions. Even the poorest of the poor want to know about what's happening to them. But that discussion, that questions, that explaining it's not about time. See, a lot of people will say, oh, but in a government hospital, it's about time. No, it's not about time. I worked in government hospitals. I worked till a few years ago. 3 or 4 lines of explanation as to why somebody needs surgery, why is it important, is not about time. It's partly about, I think it is about class. And I think that's where ordinary people find the private doctor actually more friendly. It's a strange thing, but true. So they say, okay, we don't mind paying, but we want the doctor to talk to us. Yeah. We want to doctor to answer our questions, etc. So it's a so when you compare the two systems in India, it's not just about the monetary factor. Yeah. If otherwise they were equal, logically most people should access the public healthcare system, right? Why should ordinary citizens be willing to spend large amounts of money, right? But I think it is the other factors. The private sector is perceived, maybe it is partly true, to respond immediately, be a little more individual oriented, friendly. That could be because it's driven by uh, the logic of the profit logic. So there is obviously, you want the patient to be your patient, but friendly, certainly more efficient. There's no question about that. So to go to a private facility, if you're asked to do blood tests, so let me give you this example. So the hospital I was working, the public hospital, the government hospital, we would give a list of tests to the patient. They would be given dates on 4 different days to do the tests. The X-ray would be a different day. The blood test would be a different day. Now, even the poor do not want to spend 3 or 4 days off work coming to the hospital to do the test. Therefore, if you told them that, look, you can go out, do these tests in one day or one morning, they would jump at it, even at the expense of cost, even at the spending. So we have created these two parallel systems where one is efficient, convenient, maybe perceived to be more friendly, and counterposed it with a system which is clearly uh, crowded, to an extent perceived as unhygienic, noisy, sometimes rude, um, long waiting lists, etc. Right? So when you counterpose this, uh, you know how an ordinary person will. Now, of course, therefore, what happens is that the entry into the private sector for ordinary people or even the middle class is favored. They enter the system to access care. But the problem is, if it becomes something complicated, then the bills go up. So let's say a patient comes to the casualty of a private hospital. They will get good treatment, quick treatment maybe. But let's say the person needs surgery or needs to be admitted to the critical care. There is a huge bill which they get on the third or fourth day, and it's a shocking bill. Yeah. And then they don't know what to do. And then the stress, then the hostility starts. Because for the family, they're dealing with two problems at the same time. One is the health, somebody's unwell, and the other is the bill. Every day they're getting the bills. And the third, which is that they perceive that there is no transparency. So they ask the uh, doctor or somebody else, why is the bill so high? And very often the answer is, well, did you not know about this? This is a private hospital. You came here voluntarily. So why are you not now talking about the bill? But actually, they have not come voluntarily in the sense, you know what I'm saying, that it's not a voluntary act. It's an act of under pressure. It's an act of certain perception. It's an act of seeking health care. It's not as if, they have gone, there's an analogy given, but they've gone to two car dealers, had taken 3 months to decide which car to buy, bought the costlier car, and then said, why did I buy a car? This is not, healthcare is not that, right? So they have come in distress, and now the bill is high. And that's what also brings me to another connect, and I've written a lot about this. That's what also leads to violence. The shocking violence that we see sometimes in Indian healthcare. There are many reasons. I'm not oversimplifying it. One of the reasons is this. Finally, somebody dies. A patient passes away, unfortunately. And the hospital says, pay the bill and we will not release the body. Now, I have said this. Thankfully, I work in a hospital where I have been able to convince the management that please do not stop releasing the body uh, because somebody has not paid the bill. By the way, there's a Bombay High Court judgment on that, which is really good. That the High Court has clearly said that you cannot. But just imagine the impact on the family. Somebody is dead. Often, perception is that they need not have died. Uh, you have a bill of lakhs, and finally somebody is telling you that you cannot take the body home till you pay X lakhs of rupees right now. And it's a classic setup for anger, and anger sometimes boiling over. So I think this is the chat, and this is the Indian private sector. I mean, again, I'm not trying to pin blame on a single factor, but again, going back to the approach of the medical professionals, when these violence takes place, very often you'll see in public debates uh, huge hostility and pushback from the medical professionals. Uh, some of it is, for public consumption. So people say, oh, patients have become violent nowadays. There's this discussion. Some of my colleagues will say, oh, everybody's become violent nowadays. And I have written and I've said this uh, much to the sort of, I've received a lot of pushback, and I said, where I don't see those violent patients. How is it that in your practice you say that you see violent patients every few days? I think you need to re-examine your practice. But that apart, I think this kind of pushback, putting it back on patients rather than trying to say that what led to it, can we change few things? Can we, for example, agree that we should not be holding bodies back? That's not happening. And this hostility is leading to even more hostility. It's an extremely challenging situation. And okay, so there's another response. We should have security in the hospital. There are people who have said, oh, we should have security guards at every level in the hospital, in the intensive care. It's the most ridiculous statement to make, in the sense, this is healthcare. This is a healthcare institution. How can you ever have police or security standing at every level of interaction? No patient or no family member plans the violence, right? Very little of it is planned. There could be stray cases. It's a spontaneous act of anger. It's often just a roughing up. So the doctor says, so rude behavior, or they say, oh, if you can't afford, you take them away. If you can't afford, take the person away. and you're angry and you sort of shout back or hold the collar. Now that is what it is. So now you can't have a security person next to you. So by the way, there are hospitals now who employ bouncers, and that is another story. But I'm just saying that this is another symptom of the malaise, the violence, and no good outlets, alternative, rational, organized outlets for people to bring up these issues. So in India's healthcare, if a patient brings up an issue, most often it is dismissed, or there are so-called inquiries where, I mean, I just want to say this, there is no understanding in India, purposeful or otherwise, I don't know what it is, of the concept of conflict of care. There's no understanding. It's a blind spot. So in a hospital, if a patient has a complaint about whatever, three doctors from the hospital or two administrators from the hospital will sit and discuss the complaint, either against themselves or against their colleagues. So there is no concept of understanding that there is huge conflict of interest here. And this happens across the board in committees. I work in transplantation and I've been involved in committees and, policy making, who should get organs, something as important as that. There are four doctors, three of whom work in the private sector, who are sitting and deciding that. Now, where is the understanding of at least trying to reduce the conflict of interest? And this is one area where I think we need to. So, very often, and this was an interesting experience. So, there was a consumer organization in Mumbai who, at a particular phase, started a parallel system where patients could complain to them and they would send the complaint to a group of doctors. I was part of that group, so I know I opined on many cases. And in about 80 to 90% of the cases, actually the doctors on the panel said, look, there may not be a case here. There may not be a strong case. And the person withdrew. Because what they actually wanted was somebody to hear them, to say, yes, we want to know what happened to you. Yes, there is a that also does not happen, and that can be even more frustrating. So I'm just linking the fact. So India's private care uh, is unregulated. The US, I know there are many challenges, but the US has a capacity, and I say this slowly, and I know there are challenges, but has a capacity to at least investigate and maybe often bring people to book. Um, I mean, that's a capacity that system has. That at that point, even if it's a so-called big doctor, they will often bring the person to book. Whereas here, it all entirely depends on how big you are, how connected you are, right? I mean, there's no parallel there could be parallels in healthcare, but when I heard about the insider trading and the investigation in the US, since you're talking of the comparison into, let's say, somebody like Preet Bharara investigating uh, Raj Ratnam, I mean, insider trading. I don't know, but I'm not an expert. I think insider trading in India is everyday affair. So, we don't see that as a contradiction. So similarly here in healthcare, we don't even see some issues, whether it is commission practice, cut practice. We don't see it as an issue of unfair trade practice. We don't see it as an issue of um, illegal practice, where I can incentivize a person to send patients to me with money in a non-transparent manner. Uh, So maybe that's the difference. Maybe here we have normalized many things as kind of inevitable. So, yes, it is not just privatized, but unregulated and normalized um a lot of things which are very harmful to ordinary citizens. So, this is again something that people often say, that what's the point? What's the point of talking about this in the public arena? Well, I think the point is that for ordinary citizens, they need to know because it probably helps them to negotiate healthcare to an extent. Uh, yes, there is a challenge here, which is that will it further reduce trust in the system? Because trust is important in healthcare, and one recognizes that you need to put a certain trust on the healthcare system when you access it, right? When you are undergoing, let's say, an operation, you need to trust the surgeon. So, of course, these discussions have the potential to undermine trust. But on the other hand, they have the potential to for individuals to understand what is happening and take corrective measures. And uh, unless citizens do that, or at least they push government to do that, self-correction, for the reasons I shared with you, for the conflicts of interest, is very unlikely. Very unlikely.
Yeah, I mean, about the violence against doctors, I had listened to Nandita Iyer in one of the podcast episodes, The Seen and the Unseen, where she took up medical profession, and she was a student, and then she started to practice, and uh, she saw violence firsthand, and that completely traumatized her, and she decided to leave the profession completely. So I can sort of imagine how traumatizing such an experience can be, right, for someone, and why would they even choose to be in that profession, and it can also impact their attitude towards people moving forward. So yeah, sad state of affairs. But I think
But what is I mean, just to repeat, what is also concerning is how we respond to it, and I think that's also equally important. Individuals, of course, will be shattered, but I'm saying how does the system try and analyze and respond to it? Yeah.
yeah, I don't think security guards and having bouncers is the idea, because it makes the place even more unwelcoming, right? There should be a certain sense of welcomeness or empathy, just that environment and milieu should give, which it wouldn't if bouncers and security guards were all over the place. um, Doctor, interesting points that you bring about the private healthcare in India, and I just wanted to take a look at the other side of it, which is the pharma companies. Doctors are usually sort of lured into prescribing certain drugs by the medical representatives, and it happens everywhere. It's not an India problem. I'm sure it happens all over the world. But you know, with your experience, what have been some of the really shady practices? I mean, when I say shady practices, when people have crossed the line in luring doctors into prescribing their medicines, do you have any examples?
Hmm. Yeah. So as you say, it's a global phenomenon. But again, rest of the globe has tried to, I don't know how successfully, set boundaries in terms of the relationship between pharma and the medical profession. Some countries, including the US, have fairly sharp boundaries, right? So, having said that, of course, these boundaries are often circumvented. Uh, I think what could be a little different in India is number one, uh, the number of brands and combinations that we have. It's humongous. And, that's not my territory, but to say that uh, we seem to have a penchant and uh, particularly for combining drugs. And globally, this is much less. So that's one. The second big challenge in India is how do we choose a particular brand and what is the role of, into inverted commas, generics. Now, I don't want to take a deep dive into generics. There was a huge controversy a few months ago, and I don't know whether any of your guests referred to this controversy, but the new form of the Medical Council of India, the National Medical Commission. Um, prescribed prescriptions that prescribe that doctors should only use the generic name. Now, this is actually global practice. It's nothing very new about it. And there was huge pushback from doctors in India to the point that the National Medical Commission, which is a statutory body of the government of India, actually has temporarily withdrawn their new ethics guidelines. I was a member of one of their committees, and I know that it was a pretty extensive process. And there was an attempt to bring in many areas through that the new guidelines. So, but they threw the baby out with the bathwater, and I think it's been currently suspended. I suspect it has also got to do with the fact that this is election year, and governments don't want to do anything which will antagonize. They perceive doctors in India as very influential people. They are, and so they have friends in government and friends with parliamentarians, etc. So that has been withdrawn. But so that's another area where I think we are a little peculiar, that we prescribe brands. We have lots of combinations, and boundaries. Well, there are no boundaries. I mean, of course, most of it is the small things, the pen and the stuff like that. But there are no boundaries. And again, there are two parts to this. One is, okay, there are meetings, for example, where pharma is sponsoring a meeting, so-called educational support. Fair enough, right? The question is conflict of interest. And is the conflict of interest disclosed? Now, I'm going to give you an example from COVID, because I just cannot forget it. And I remember it sharply because it was in the peak of COVID. So in the peak of COVID, there were a lot of new drugs or antivirals which were being pushed, right? And partly because there was chaos, there was fear. So, I mean, I can understand companies wanting to get onto the bandwagon, partly wanting to push new drugs. And, the US, you saw that, remdesivir. A lot of things happened. But there was a prime time television interview by a very well-known journalist of two doctors. And it may still be up there for somebody to see, where there was a trial of a so-called new drug. The trial itself was shabbily done, very limited numbers, some 12 patients or something. But he interviewed the principal investigators of the trial, who spoke glowingly about the drug. And one of them, I think both of them, but one of them certainly was paid by the company as a principal investigator, was an advisor to the company. Now, the way it could have been done is the person interviewing could have said, this person is being paid by the company. Okay, listen to his views. I'm not saying don't listen to their views, but disclosure. So let people interpret what a person is saying with full knowledge of what are his conflicts of interest, right? That doesn't happen here. Now, whether it happens across the world, so there is a big push to disclosing, and disclosure is largely followed, and there is a lot of consumer resistance to conflicts of interest and obfuscation. So in the US, for example, ProPublica, which is I maybe you have come across their work, so which regularly exposes conflicts of interest in the pharma and medical. That does not happen here. So as a result, therefore, new molecules, be extremely costly, can be pushed. And of course, there is one more thing in India and many parts of the developing world, which is that new drugs are exceedingly costly. Cancer drugs, some of them very effective, but there is no sense here. It's beginning to happen, but in a very limited way, of what is called cost effectiveness. So when you are, let's say, prescribing a drug, which is a cancer drug, which is used for, let's say, advanced cancers, right? Yes, there are some medications which add a few months to life. There is an individual patient who may choose to say that I want to take the medication. I want to live for 3 more months or 6 more months. I mean, that's everybody's right. Why not? But the question is, these drugs are pushed by the industry through doctors associations as life-saving drugs, right? So the person is paying sometimes lakhs of rupees for a drug which has either limited value or has limited impact, but is hugely costly, right? So there is no complete disclosure. So I think besides the fact that there is the relationship between pharma and the medical profession, obviously there is lots of boundaries crossed, and I don't even want to talk to you about some of them because it's completely embarrassing things like people. It's not even minor. It's like people being given cars and all that, and it's people having their children's birthday party sponsored by pharma, etc. But this is again, as I said, the whole Sackler story in the US, and so we know that they have taken it to a fine art. And the question I want to address is, how are we as professionals in India and our professional bodies, how do we respond? And I'm talking of big organizations, the Indian Medical Association, the Associations of Physicians of India. How are we responding? It is not about morality. This is, there's an interesting. So this is okay. Morally, people say, oh, but the moral fiber is down. So this is not about morality. If you leave it to individual morality, we have lost the battle. I think this is about professionalism. Professionalism. This is about collective thinking in the interest of our patients, right? And that is where I think the spectacular failure, if you ask me, in India is of professional organizations to deal with these issues, uh, come out with their own set of guidelines and code. And peer pressure is extremely important. In many countries, that's what works. No doctor wants to be seen to be crossing boundaries if their peers will not like it. Here, unfortunately, if a doctor organizes a big conference where everybody is entertained at the cost of pharma, actually that doctor's image in the profession goes up a few notches because his hospitality offered by that person. Oh, what a lovely meal, what a lovely entertainment program, etc., etc. Yeah, without thinking what does this mean, and so it's the relationship is a old challenge. By the way, sections of pharma are very uncomfortable with this. I mean, most of them, of course, want to influence doctors, but they are uncomfortable because some of them actually use this term with me. Senior people, they say, we are being extorted. We are being extorted. We are told that you better support this meeting. Otherwise, we'll stop. We will send a message, a WhatsApp group that will stop prescribing your products, etc., etc.
It's become like a
So,
cartel, kind of.
absolutely, that's the term. It's a cartelization, and it's very deep. Now, there is also a link to hospitals. Which is another story, but which is a very important story. So you walk into a hospital in India and you are admitted, you are prescribed, let's say, an antibiotic, a costly antibiotic, right? So most hospitals in India, at least the big hospitals, will not allow you to buy a drug from outside. The drug has to be bought from the hospital pharmacy.
Even if it's the same brand, everything.
Same brand, the same drug, 2 minutes away outside the hospital in the chemist, but you have to buy it from the hospital. Now we must understand this. So why is it so? So the biggest money spinner for hospitals is the pharmacy. Because, and this is a game which it's not about hospitals, it's a game being played between pharma and hospitals. So pharma gives the drugs maybe in bulk, to the hospital at a much lower cost, the much lower cost than the MRP. So when you see the MRP, that's not what the hospital has bought it for, right?
Just to interrupt you there, what is the hospital's justification? Let's say I am a patient or I'm the family of a patient, and the hospital says that you have to buy drugs from our pharmacy. What is their justification? Like, why do they want you to do that?
Right. So that's a important question. So first of all, you are in my hospital as a patient, you better follow the rules. That is one subtle justification, but that's the ideology, right? Secondly, this is the obfuscation, I think, that look, we want to ensure quality. So we will not give you drugs which are of lower quality. Now, that's where the obfuscation is. Because in India, cost does not equate quality, right? Uh, there are drugs, injections, which are one third the cost from reputed companies, right? From very high quality medicines, because the original molecule is costly. And now, the whole Indian health, pharma industry has made many drugs of good quality, which are significantly cheaper. So they assure quality. Uh, but again, I'm coming back to that. As a doctor in that hospital, am I not interested that the patient who's admitted under me uh, gets treatment at a lower cost? And the cost differences can be substantive over a period of time. Yeah. Also, okay, you do this. You tell me that you have to buy medicines only from the hospital. You tell me that I can't buy from outside. Why are you not telling me that there are even three brands in the hospital, one of which is cheaper? There is no transparency there. Okay. So therefore, it's very clear that it's a cash cow. It's very clearly a cash cow. And now my question is, who's going to change this? Who's going to question this? In my view, consumer resistance, as I said, is very low and naturally low. At the end of their hospitalization, I mean, for me, it's every week I face this. A patient comes to you with a huge bill, and it's sometimes astronomical. Unfortunately, there has been some complication. They will start looking through the bill, and they are aghast. Now they look at the costs. Say, doctor, this same medicine I asked outside in the chemist is one third the cost, or one fourth the cost, or half the cost, or there is another equivalent which is half the cost. Why is the hospital charge me this? And now I can have two approaches as a doctor. One is I can say, look, don't ask me. That's not my problem, right? But how can I say that? This is a patient who's come to me. So I have to give an explanation. And this is where I think the doctors will have to try and say, look, either ask the right person or this is not of my doing. I do not agree. I sometimes say I do not agree, right? What I also do, and thankfully the hospital I currently work in allows me to do it, is to say that please allow this patient to buy drugs from outside. So they do that, yeah. But let's understand what this is all about. So every opportunity during the hospitalization is used to make money. Now, one of the questions is, do I have anything against making money? Well, that's a separate discussion, right? Uh, we can have a discussion about that, making money in healthcare. But certainly, is there transparency in the process? Is the person being given a choice? Are you open about it? Are you clearly stating that a large part of your income is through the drugs that you are there in your pharmacy, and that there are three drugs of three different costs, and that the patient has a choice? So this is where it is. So even if you're making money, fair enough, make it transparently, uh, and let the consumer, it's a horrible word to use in healthcare, but let the person also have their say. So I think this is where probably we are a little different. And I come back to what I said earlier on. So it's not just about a privatized system. It's about an unregulated system, an opaque system, and about a system which has actually unfair trade practices. there are trade practices which could be fair, but the commission system, for example, which is completely opaque, uh, is unfair to the person. Okay, you can have a transparent system of splitting fees, or officially giving what is called all sorts of sophisticated terminologies. So I think that is what it is, and that's where I think there's urgent need for reform, and I think the state is beginning to understand this because they get pushback, right? So they try to control, but they are half-hearted about it, very half-hearted about it. And I say this publicly because, I mean, some of us have been involved in regulatory work, uh, but there is huge pushback from the medical profession. But that's not the point. The point is, as I gave you the example of the uh, National Medical Commission's uh, ethics guidelines, which were developed over 2 years, they have been withdrawn. So the ability of the medical profession to stop regulation is also worrying. And that is something that citizens should take note of and, push government to, to intervene. Only in COVID we saw that streak. I mean, they had to respond because, they knew it's a crisis of, there also there was challenges, but yes, they did. I know in Maharashtra, they did respond, capped fees, etc. But what about normal situations, where, somebody walks into a hospital with an emergency? What happens? It's very sad. And this is again something that if you have family, friends, they will tell you. Then Indian cities, big Indian cities, if you have an accident, if that accident happens in front of a big private hospital, often the police will take you 20 minutes away to a public hospital. So they are worried that how can we enter this hospital? What will happen? Where the Supreme Court has judged this, that no emergency can be turned away for the sake of money, for the sake of the bill. But people don't enter because they're scared. And if they enter, very often, not always, there are exceptions, of course, and there are good exceptions, but otherwise, they are told that, look, you will not be able to afford this hospital. Maybe they give some emergency care and quickly shift the person. So I think this is where the state has to step in, which has not happened in a big way. Yeah, although the many medical professionals in India seem to think that their independence to practice is under threat. That's what they seem to think, without realizing that actually we are the least regulated. Unless you see that system closely or work in that system. I mean, for example, in most, I worked in hospitals in, of course, in the UK, but I've also fairly closely seen hospitals in other countries. You cannot prescribe a drug that you want to, just because you want to prescribe it. Antibiotics. What is fueling the antibiotic resistance crisis in India? South Asia and India has the highest levels. Because I can prescribe. You walk into my clinic and you have a cough, I can prescribe an antibiotic to you. Nobody's asking me why, for a viral fever, the prescriptions during COVID, for example. So this feeling that we are doctors and therefore we have a right to do what we wish is untenable anywhere in the world, and I think it should be untenable. It should not be that way even in India. Rational practice based on evidence, our participation in national priorities, whether it's TB, where I cannot be just giving a dose of TB drugs that I want to, right? Where I need to be monitored, is something which is a collective good. And unfortunately, currently the profession is very hostile to all this, but it needs to be slowly changed.
Yeah, looks like the profit from pharmacy makes up for a good chunk of the overall profit that a hospital makes, right? They get medicines at a very discounted price, and they get to sell it at MSRP or MRP, which is quite crazy. Yeah. Doctor, I would like to move a little bit onto transplantation and medical tourism and issues with transplantation in India. I read a very interesting statistic that women form the majority of living organ donors, and I wanted to understand: is it because of societal expectations and sort of the expectation that the woman has to sacrifice for the man, and so on? What have been some of your observations in that area?
Yeah, yeah. So I recently actually did a piece on this, uh, looking at trying to look at again what is the reality and what is driving it. See, there is outrage on the fact that women seem to be donating more than men. It's not women, but often it is wives. So there is a difference, right? And I think in kidney transplantation in India, it is true uh, that women live donors very often are women and very often are wives. For that matter, occasionally the marriage is done so that the wife can be a donor. Because this is related to the Indian law. The Indian law says that if you have a close relative, so the close relative is defined as father, mother, sister, brother, son, daughter, grandparents, and spouse. Then you don't need any special permissions. The donation is relatively quick in terms of the paperwork and the permissions. If it is somebody beyond that, then you need a special kind of committee, etc. Because where does this come from? So we need to first understand why is first of all this law there. So in the 80s and 70s in India, kidney transplantation was a free for all where organs were being bought. In the city of Mumbai, hospitals were flooded with patients from the Middle East who would come here. There would be agents who would pick up somebody and say that we are willing to offer you X amount of money, lakhs of rupees. They would be brought in, young people. The kidney would be removed and would be transplanted into some wealthy person, often from the Middle East. So there was scandals, and obviously there was genuine outrage, and the government decided to step in. So there was a law which came in, and the law primarily came in because of these scandals and this history. So
This
it
is what
focused
is
on.
medical tourism, right?
No, I'll come to that in a minute. What constitutes medical tourism, and there could be various types of medical tourism. But that stage, it was just people walking in from other countries to buy kidneys. Now, that is really not medical tourism, but we'll come to that. This law said that we will only allow uh, donation for under circumstances where the donor is donating under for altruistic reasons. Now, I would be the first to admit that, of course, even in close relations, you could have a little push, a little even money exchanging hands. I mean, of course, but that was the logic. Now, therefore, the spouse was a donor who was legitimately allowed. Now, therefore, if you make that connect, a lot of wives were donating. Now, you can have two views on that. The one is the benign view, or the less, you can say, a more benevolent view, which is that wives are, of course, look after families. Women have, there's the construct that women, their instincts are more whatever.
It's also called benevolent sexism, where
Yeah, yeah,
yeah.
benevolent sexism. But yeah, so women has to cook, etc. So yes, so I think it's that. The second view, and which is I think very clear to me, is that the woman often is. I'm not saying when we use the word coercion, we're not necessarily talking of they take them dragging and kicking to the operation table, but that, that it is your duty, job, etc. Yeah, that is caution. There is no question. Subtle, familial, societal, their role. Now again, there is a question to this, which is that how should we respond as a transplant? So I'm a transplant surgeon. I have interacted with families, although I wasn't involved more in liver than kidney. So how do we respond? Now, again, we can take a bystander role, which is historically what medical professionals in India have unfortunately done. And I will take you back to two other similar situations. Not exactly the same, but similar. One was female feticide. So parents would come, meaning the mother and father, and would come to the doctor and say, Doctor, we want to identify the sex of the fetus because we don't want a girl child. Now you can say, okay, fair enough, I'm offering a service. I do it, tell you the sex of the child. And okay, you want to abort, I abort. It's my job. And I remember doctors saying that, look, we should do this because it will contribute to family planning. Because that time we were on a family planning high in India, right? Every problem of India was connected to population. Even now, people talk like that, but it's much less now. But that time, our problem is population, right? So therefore, they don't want a female child. So that is one. The other area where we saw that women it was assumed that it is a woman's responsibility was, again, in family planning, sterilization. At one stage, it was women who were getting sterilized. It was their responsibility to sort of undergo the operation, and fairly coercive. I worked in a medical college and hospital in Mumbai as a student where the woman was told that if you have to register in this hospital and if you have a second delivery, the only reason we will deliver you here is if you allow us, if you agree for a sterilization procedure after the delivery. Otherwise, we will not deliver. So that kind of thing. So I'm saying that there has been a bias against the girl child, women, and I think here, to an extent, this is how many people look at it. That's not our job. So this is one of the aberrations. But I think it brings me to a larger point, which is not related to only to the gender issue. So when you have living donor transplantation, and today we have a lot of living donor transplantation in India. So a live relative is donating either one kidney or part of the liver. Both are formidable operations. Certainly the liver, which is a big operation for the donor. We must first of all understand that it's not some minor procedure, which both short-term and long-term risks. So therefore, when we as transplant surgeons say that is a procedural thing, I have nothing to do with it, right? It's not just about the woman being coerced. It's also about where do we stand on coercion in general of the donor. Intra-family coercion, out-of-family coercion. By the way, in India, it was pretty common and still occasionally happens that the driver donates to the owner whose car he drives. Oh, yeah. And, when asked, they have said that, the driver is working for 25 years, so the driver feels a lot of affection for the owner. I don't know whether you read Arvind Adiga's novel, The White Tiger, and the movie. It's very interesting. But I'm saying that drivers, maids. So where do we stand on this? Do we like this idea? If not, should we be intervening? Right? So when I wrote in response to this just a few days ago, one of the things I said was that as a transplant surgeon or a physician, you can always take the donor, talk to the donor privately. We have done that. And say, look, if there is coercion, I, as your transplant doctor, am willing to give you a medical reason so that you cannot donate, so that you don't face the wrath of your family. Now, this is a practice that is followed in some countries, right? Because, see, for the woman to tell her husband or in laws or larger family that I don't want to donate, right, is difficult. It's huge pressure. By the way, women whose husbands are, I mean, I'm not trying to say we should not treat alcoholic liver disease, whose husbands are alcoholic liver disease patients, the women wives donate. Uh, so so this is what can be done. And when you do it, I have faced this and I've written about that, that there is small section, I'm not saying the majority, who will tell you in private that, look, doctor, please do that. I do not want to donate. Right. So again, it is about how we respond. Uh, yes, we are torn between saving the life of the husband or the male member. In kidney, it's not saving life, but enhancing the life because they go off dialysis. In liver, it is saving life. But also about the rights of the donor. Is it a voluntary act? And transplantation is full of such challenges. And I think what is happening is that, see, transplantation came to India uh, years ago, but has shot up in the last uh, decade or so. And we must acknowledge that a lot of doctors trained in transplantation in the West or in abroad and came back and now are offering that service. And in a sense, it has opened up many possibilities. So heart transplants are being done, liver transplants are being done, etc. So, for example, 20 years back, uh, Indian citizens could not access these transplants. So, in that sense, we have moved ahead. Yeah. And I think there's fair amount of technical expertise. Uh, so I think that must be acknowledged. But having said that, what has happened is that transplantation has come into a healthcare system which is highly privatized, which is unregulated, and has conflict of interest. So therefore, the same factors which we've been talking about, they operate in transplant, which makes it where the stakes are even higher, where the costs are even higher. So, for example, in a transplant, the costs are humongous for the patient, and if the transplant is done for the wrong indication, because again there is a push for numbers, and there is a recurrence of the disease within a, let's say, 6 months. Uh, the family feels cheated because they have spent astronomical sums, and the disease is back in the transplanted organ, tumors, etc. Or for that matter, when it comes to allocation of organs. So now that is another big challenge and big area. So we have disease donation. So individuals who either in their lifetime have committed to donating, or their family members after the death of an individual, something called brain death, are committing to donate organs. Now, why are they committing to donate organs? Or why are they willing to donate organs? Purely as a altruistic public good, right? Just think about it, that somebody is dead, the close family member in moment of intense grief is willing to donate organs. And it's an amazing act. When I came back from the UK and we started promoting the idea of donation in India uh, after death or after brain death, my initial thought was that nobody will agree. But I'm surprised. I was surprised. And very ordinary people, parents are donating the organs of their small kids who have died now, but they're donating it as a public good, right? So, what should be ideally happening? That the organ should go to the person who's the most needy. That is the global principle. Yeah. Now, if we examine India currently, so there are structures, there are systems, but unfortunately, again, 90%, if not 95% of transplants are being done in the private sector. Now, that is a bit of a discussion as to why the public sector cannot develop it. We can address that. However, therefore, the organ often goes to the private sector, right? Because they are the ones who have the capacity and they are the ones who can bear the costs. But what it means, therefore, that a public good of a donated organ is going largely to private interests. And also because the hospital it's highly monetized, they are under pressure often to give it to the patient who is paying the most. Now, I say this with partly with caution because, yes, there are monitoring systems, but I say this also as somebody who's worked in the system, who has seen it very closely, that even for the transplant team, there is a pressure to give the organ to the person who can afford it or who can pay the maximum money. Because it's clearly a profit-driven enterprise. So that's the distortion. Having said that, yes, it is true that transplantation in India has advanced a lot. For an upper middle class person, a well-to-do person today, there is a possibility of getting transplantation if they need it. But that's not the same as a national transplant program, which essentially is based on not on your ability to spend, but your ability of need, whether you need a transplant. Yeah. And I gave you the example of the NHS. Now, of course, going back again and again to the NHS may sound a little repetitive, but in the UK, we have taken part in the transplant of a student who was in the UK on a student visa temporarily, who came down with liver failure. And the person was transplanted, no questions asked, from another country. The person was from another country so that is the system there, right? So that is the challenge in transplantation. And why is transplantation sort of a test case? Partly for me, because I was trained as a transplant surgeon, so I've seen it at close quarters. But I think it's a test case also because we want ordinary citizens to donate organs. Otherwise, it won't work. But if they do not have trust in the system, if they cannot see the system as transparent, as justice based or just, they will not donate organs. I mean, any study across the world of countries who have large number of donations after death, after brain death, will tell you that it is because people have trust in the healthcare system. So I think that's how it is connected. Now I will come to something you raised about medical tourism, because transplantation is one area where there is a lot of now medical tourism where foreigners come to India for treatment. Now, medical tourism is a big industry. And I think let's accept that it is being driven largely or partly by the fact there are many countries which do not have the necessary wherewithal or the facilities to do that. So do a procedure. So for example, liver transplantation, kidney transplant. We get lots of patients from Africa, which is underserved, which does not have the facilities. So people will travel. Look, everybody wants to live, wants to get better. So people travel for healthcare. So you can't stop that. But then there are 2-3 questions that arise from that. One is, of course, if people are traveling, what impact? So people traveling to India or any country, accessing care in the private hospitals, what is the impact on local patients? Because typically people who come from foreign countries will pay more, typically. So the question is it making an impact on the image of the procedure, on the priority of the hospital and the team? So that is one question. The other question, of course, is a lot of this travel. Now, when I say a lot, I'm not saying the majority, is essentially commercial travel where even the donor. So a person comes for a transplant. They get their own donor from so-called family member or so-called relative. We have no way to verify that. Yeah. Sometimes the embassies give certificates, but uh, so it may be a cover for paid donation. Now, there is another level of debate here, which I currently don't want to get into. But yes, I mean, I am acknowledging that that could be a level of debate where there is. So there will be people who say, "What is wrong with paid donation? After all, the person is getting an organ removed," and there is actually a school in philosophy and ethics, and some of them are quite active in the US now, who say that we have a market for everything. So why not a market for organs? But let it be a transparent market. Let it be a fair market. Even markets need to be fair. So yes, we can buy organs, we can rent wombs, we can, but let it be fair. So that's a different level of discussion. And but I'm saying that these are the challenges when you have medical tourism. Finally, of course, see, I find it very odd that I'll pose it to you that we have huge challenges for our own people in terms of accessing care, day to day care, huge challenges of delivering high end care to our citizens, right? Now, whilst that is so, what is this whole focus on medical tourism? I mean, to use a recent sort of trope, this is not nationalism for sure, right? Okay, there's bringing in revenue. That's one argument the government makes. But are you using that revenue for improving the healthcare of our people? I mean, there is an argument which says that we can play Robin Hood, whereas the money that you get from the revenue, you use it, but then demonstrate. So even hospitals can do that. They can say, look, the money that we get from medical tourism, we will set apart a section for subsidizing the treatment of. Now, some of them actually say that if we do that, but it needs to be more transparent. It needs to be proven better, if at all that is the argument. Yeah. Otherwise, essentially, what we are saying is that this is all about money and that the needs of our people can wait, but currently our priorities, because I have invested in a hospital, I need quick money back. So I will focus on medical tourism and sort of the state will say, okay, it's a great idea, etc., etc. So I think it's a question of also state policy and what are our priorities. I mean, you have these two parallel things, which is very interesting. That there are individuals in India who have completely gone and worked in highly underserved areas, set up hospitals, set up healthcare systems because it's so underserved, right? Cancer care. Uh, and then there are these entrepreneurial doctors who setting up these posh hospitals uh, with the idea that they will attract people from across the world. I mean, so just look at this strange sort of coexistence. I guess it's a sign of the times, and obviously, but it's strange. But what is even stranger is that it seems to me that the state in India, the government, seems to feel very highly about individuals who have built these big hospitals and are into medical tourism because they are the ones who get a seat at the table. So when the American president uh, visited, Obama visited India, and he was introduced to the leaders of healthcare. So in line were some of the owners of private hospital chains to meet him, right? In my view, fair enough. Maybe they could also be there, but the leaders of healthcare should have been people standing there, should have been people who have, set up large rural projects or who have, engaged with policies, changed policies, uh, maybe looked at people who have worked in rural Tamil Nadu and have changed the healthcare system. So, what do we reward is also an important question, right? What does the system reward? And currently it seems to us that, and again, I come back to conflict of interest. If you have healthcare chain owners who are in policy making bodies, what is the chance that they will tweak policy for their own good? It's a high chance. I mean, they want to survive, so they will impact on policy. Uh, it's a no-brainer actually, right? And therefore, the question for the government, for Niti Aayog, for the Medical Council, the National Medical Commission, the Health Ministry is, who is guiding you? What are their interests? And what are your interests? And if your interests are aligned with the interests of people, is there a conflict of interest? Is what you have to see. Otherwise, you will have the pharma industry advising you on how to do pharma policy. You know, so I think that's the conflict of interest issue, which I said right at the outset that we don't seem to even understand that for in public policy you need to look at this very, or maybe we understand, but we do not have the courage or we do not have the interest to change it. Either of the two, you know. Even the advanced privatized healthcare, market-based healthcare, right? US care, yeah, uh, needs to have transparency, needs to have clear demarcation of conflicts of interest for it to be viable and survive and have some levels of trust. Even in the trust antitrust cases, which is now involving large software companies, right? So healthcare is even stronger levels of trust are needed, and stronger levels of monitoring are needed.
Yeah, I think, Doctor, you answered so many questions that I wanted to ask. And before we end this podcast, I just want to touch on one specific thing that you mentioned, is that I don't think a lot of people are hesitant to donate their organs, or their own organs, or their loved ones' organs. And there seems to be a debate on who is the most needy, and it seems like right now whoever has more money is more needy, and that's how the transplantation is done. And you also mentioned about like a national transplant scheme. Can you tell me about how you sort of dream about a very fair system of organ transplants, and how does someone decide who is the most needy?
Right. So that's, of course, a little challenging question. I'll tell you, the challenge in India is that there is structural inequity, right? I call it, I have recently written somewhere saying that we have transparency in India. We are transparently inequitable. So you can have transparency in inequity, right? And happily live with it. But I think what, as a country, we need to look at is, number one, the distortion that it's become a pure private sector activity. Any government which wants to take this forward can establish transplant units. There's no short dearth of money, I think. There's no dearth of expertise. Transplant units in all the large cities, in large public hospitals. So that's point number one. Point number two, if we feel there is still a discrepancy between the imbalance between the private and the public sector, one of the things that governments can do, and they're well within their rights to do it, is to actually push the private sector to deliver the transplants either at a lower cost, or a part of the transplants to be made done absolutely free of cost at a very low cost. And I'll tell you the rationale for this. The rationale for this is like this. So people say, but why should a private hospital serve the public, right? It's their own money. They have put in money. How can you force them? So let's remember a few things. Number one, most of the doctors working in these hospitals are trained in public medical colleges, which means taxpayers' money is being used to train them. Medical colleges in India are heavily subsidized by taxpayer money. Number two, many of these hospitals get subsidies because they are a hospital, land, electricity, etc. So they are being supported partly by public money. And this is a truth which people need to understand, that for a private sector hospital to say, I'm not bound to do charity, well, then you also don't take charity from the state, right? So that is point number two. The third thing, of course, specific to transplantation is when you want people to donate organs, right? You want ordinary people to donate organs, right? You go out in the public and conduct a campaign. Now, they should give you, but when it comes to receiving, you will be selective. Now, that's not on. That that's intuitively is unfair, and people are not stupid, right? They understand, right? And therefore, at some point, they will question this. That it's like, okay, you want me to donate blood. Now, when I need blood, are you going to ensure that I get it? Or my family member needs blood? If you are going to charge the blood bottle heavily, then why should I donate to you for no charge? Then you take my blood, pay me, and then when I need it, I will pay to you. So I think that is the understanding in voluntary donation, of whether it is blood, whether it is now, as I said, there is a ideological challenge there, which is that why are you insulating transplantation from market principles? Now that's a different discussion. I'm having to willing to have that discussion to the people who want to with the people who want to do that. But I'm just saying that that is the challenge, and it is for the state. But again, just before we conclude, so what is the state? Who is the state? I referred to this entity called the state in my responses. So who's the state? How does the state behave? The state is behaving uh, in response to what they perceive as either what people accept or people tolerate, or the state behaves under pressure. So if there is no pressure from people for the state to behave in a more fair manner, to intervene, they may not. They may not. They have largely, those who are part of the senior state apparatus have sorted it out for themselves, right? It's like doctors have sorted it out. They think that if they need an organ, they will get it. Yeah. But so there has to be pressure, and also so I know it's a very loaded term, and I'm not saying that one needs to always talk about in a very loaded terms, but you see, what should an enlightened medical profession do? I think that is the question. Just do our job and go home, or say no, we want to improve access for our people. We want to intervene. We want to give our inputs to make it more fair. And in transplantation, that is a no-brainer, that if you don't make it more fair, don't make people feel a part of the system, they will not donate organs. So I think that's kind of where it comes from. And therefore, I think there is a question of who will bell the cat, who will change things, or is it just a matter of sort of time? I don't know. I don't know. I hope that it is not just about time, because if it is just about things changing with time, then I don't know. But if there are forces which are pushing to change it, and we are beginning to see pushback. We're beginning to see pushback from patients, from professional patient organizations. I would say even pushback from governments. More and more governments in India are attempting to regulate things, but we need to remove all the other cobwebs that we have right now, right? We have a lot of cobwebs, mental cobwebs. We need to move to healthcare as one of the chief main areas of intervention. Because, if we end up being the sort of so-called cradle of civilization, whatever that means, but our healthcare is in shambles. What does that mean? What does it mean that we are slowly sliding below Bangladesh in terms of our health indicators, right? So I think it comes from there that if we are really a world power, a world power generally looks after the healthcare of its ordinary citizens. At least doesn't allow them to die from preventable diseases. So we approach it from that construct, then maybe we will do more.
Yeah. Yeah, I absolutely agree. And looks like, if you want to be a Vishwaguru, you have to be Vishwaguru in healthcare as well. And to your point about government or the state intervening with private hospitals, looks like the big brother can sort of intervene, and because of the all the subsidies and the educate, the government or the state giving heavy subsidies to education. So looks like there is some possibility there, and definitely it will be nice if there is a national transplant scheme implemented, and the deserving people get the right. So yeah, thank you so much, Dr. Nagral. I think it was a fantastic discussion. I learned a lot, and I'm pretty sure the listeners will learn a lot. So thank you so much for spending 2 hours of your valuable time. I know we went a little over, but yeah, thank you so much.
Thank you, Bala. I think it was a great talking to you, and thank you very much for this opportunity.